As always, we start with the new things that we do in the office. We always like to tap into the body's own ability to heal. Taking the patient's own blood, spinning it, getting the growth factors from the platelets, and using that concoction with bone grafts, with soft tissue grafts, to just get better results, to give our surgeries the icing on the cake and give it the extra benefit. So if we did this for about 10, 15 years, and we were able to create great bone and great soft tissue, the next level is to take the same material and now form bone in a form of sticky bone. Why do we need that bone? We need great bone for implants, obviously. This is about 50% of our practice, implant-related procedures. So some of the new things that we're doing, these are the impression copings. You don't take a physical impression, but the camera, with a few sensors, captures the position of those copings just with the camera. It takes a few seconds, and it captures the orientation of those copings and records them in relationship to one another. And then from that alone, you can make a mold and you can make a reconstruction, and it's extremely accurate. A full upper, full lower with implants. So a lot of new things are happening in our practice, but our biggest innovation, okay, drum roll, is Dr. Lloyd Herman, who just joined us. Dr. Lloyd, and it's a blessing that we got to meet him about 8 years ago at the Beverly Hills Academy. Really nice guy, friendly, originally from Montreal, Canada, from McGill University, then University of Colorado, a successful dentist in Aspen, Colorado. So he knows how to deal with Beverly Hills type patients. And my rule was, he's not going to get the job if he can't do the Calabasas stairs, okay? So if you've ever done them, I challenge you to do one, okay? It's not the Santa Monica stairs. This is Calabasas stairs. This is like next level. So I think we did like 5, 6 up and down. I took my kids. He brought his dogs. And then he got the job. So he's now in our office. And he's seeing patients. Patients love him, number one. He does beautiful work. He does things a little bit different than Ari and I. Ari is Ari, Ziv is Ziv, Lloyd is Lloyd. Different personality, different approach, a bit more holistic, but also does perio, very precision surgeries and very meticulous in what he does. So Lloyd, thank you for joining us. Okay, and Lloyd is also going to be part of our education. So we do a lot of education for dentists, but also education for patients. And if I want to give you one tip from tonight, forget about implants. Educate your patients about what you do. It pays dividends. We call it Periodontal tips. And we talk about health. We share things from our practice, how it can help them, and it really boosted us during the pandemic. Tonight I'm going to talk about how to get success with implants, but not the obvious, not the things we usually talk about. I'm going to talk about a couple of aesthetic nightmares. We've all been there. I'm going to talk about principles of planning, how we do precision surgeries that are simple yet very precise and accurate. And I'm going to talk about the soft tissue. And the key to the success is really the patient experience. I'm going to start with the end. The patient's experience and their trust in you is what's going to make the big difference. And our practice is 50% perio, 50% implant, and implant-related procedures. So from our work together, we all know that this is all that we do, and I'm including soft tissue grafting in perio. So it's not uncommon for patients to see us for both soft tissue grafting and implants. So this patient came to see us for recession, so she's a pretty good candidate for gingival grafting. But she also came for an implant. So she had a tooth missing for about, I want to say 20, 30 years. And she had a 3-unit bridge. Ziv, can you do an implant? So I'm like, you know what? You had a bridge for 20 to 30 years, something like that. I think what we should do, since you don't even have the bone, I think we should do another bridge. That would be the simplest, the most predictable, plus you don't need that grafting and all that cost and pain and discomfort. She said, you know what, I trust your opinion, but I'm going to get a second opinion and go get my implant. You don't have the bone, so you might need some grafting. Okay, here's the thing. So she asked me, Ziv, can you just be my consultant? Can I just check in with you every once in a while to see how things are going? I'm like, sure. Do what you want to do. Go see that other doctor. And he's very good, he's very experienced. I'm sure he's going to do a great job. So a few months later, she comes back. She comes back, and it looks like that. Okay, so we can all see something is not 100%. So I'm like, Judith, what happened? What's going on? What happened here? Well, we had a bone graft because she needed the bone. So we have the bone, but we lost some of the soft tissue. So I took a radiograph, and we see, there was probably a titanium mesh with bone grafting. We start to see that the adjacent teeth get compromised. I'm like, you know what, Judith? That's not going to work for you. It's not going to work for you. You got the bone, but you don't have the tissue. So why don't you let's go back to the drawing board. Let's get that 3-unit bridge, and we'll get some pink porcelain, work with a nice lab, and get this right. And no harm done. Sometimes surgeries, even in the best of hands, they don't work out. Okay, I'll go back and we'll find out what happens. Okay. So next step, go back and maybe do what? Maybe improve things. I got the implant. So she comes back with the implant, and it's very well positioned, and it's very precise and accurate, and the adjacent teeth are, getting compromised, in the process. And this is what it looks like now. So what happened? So we call it from bad to worse. From bad to worse. So what are we going to do next? Any suggestions? If you have any great ideas, well, maybe we should go for the bridge now. Okay, that was the last time I saw her. So aesthetic nightmares can happen even for the most qualified surgeons, the most experienced. It's about case selection. I selected not to treat this patient because the most common sense was to repeat what she had. And now we are in this type of situation. How can we avoid nightmares? So I identified only 4. And these are the 4 I'm going to tell you right away. So the first thing, and that's the key to success, is patient communication. No BS. Our patients don't like BS and beating around the bush. Tell them what it is. Tell them what you got, what it's going to be involved, how long it's going to take, what are some of the risks and complications, how it's going to cost. Transparency in everything. Deliver with conviction, with transparency, and you get the patient on board. If you don't have that, all the rest doesn't matter. And if you have that, and you get the aesthetic nightmare, you'll be okay. The patient will be understanding. Step 2, you need to have a solid plan. Solid. Precise. You got to have a good plan. Every good treatment starts with a good plan. And you need to be able to replicate that plan in a surgery. Replicate it. Because you have one plan, and we're not talking about boxing or martial arts. You get hit and you change the plan. There's a certain plan. You want to replicate it in the patient's mouth. 1-to-1, if possible. And lastly, the 4th part, not less important, is the patient experience. You can do the best treatment, but if the patient had a bad experience or felt pain during the procedure or had some post-op complications, it's bad. Where are those 5-star reviews we need, right? That's not going to give you those 5-star reviews, maybe 1 or 2. Okay? So what's interesting, once I created this lecture the past weekend, it always starts and ends with the patient. That's the key, and if you ignore that, it's not going to work out for you. So I call it the sandwich technique or sandwich principle or the hamburger principle. What does that mean? You got your hamburger, you got the bun, you got the patient on each side, top and bottom, then you can pick your meat. You can get beef, or you can get turkey. You can get Impossible Burger if you want to eat something that tastes good but you don't know what's in it. And then you have condiments. You have condiments, and that's the plan. And that's the sandwich or hamburger principle. And that's what I keep in mind. Patient communication, like I said before, in order to communicate, we need to know who our patient is, our implant patient. We need to know our patient. This is a Beverly Hills patient, Beverly Hills, LA, what we call the high maintenance in Malibu as well. Okay? So who is the implant patient? Our patients are confident and grateful, meaning they have confidence in us as they show up. They come with that confidence. They're not questioning, and they're grateful to be in great hands because we get great referrals from all of you, and you really tee it up for us so beautifully. Same patient appreciates value treatment. They know what they're looking for. They're looking for the nice car, the nice real estate, the nice circle of friends, the good restaurants, and it's not just superficial. They're looking for the quality and value treatment, and they can afford it. It's a great thing. And when they can afford it, and all of this happens, they expect the best. So it looks like an ideal patient, but even so, don't be lax. Because the tendency is, these types of patients, Beverly Hills, they can afford it, they're sold on the treatment, but then we get kind of lax. It's going to hurt your treatment. So don't take it for granted, because the same patient expects the best. So with this type of patient, and I know that you are seeing these patients, but I'm just refining the concept here. Again, this is the most important thing. These patients don't like BS at all. They come with a problem, you share with them, you make a good impression, you share the treatment times, cost, technicalities, a little bit of technicalities, failures can happen, all of that in a very short and concise way. Quote the fees. I quote them in the chair. I mean, we have Nazi, and we have Michelle, and we have other team members that present the details and the consent forms and the DocuSigns. But in the chair, they're going to ask you, how much is it going to cost me? Say it. It's the elephant in the room. If you don't say it, you're not perceived as confident about not to the dollar, but the big picture. You know how much things are going to cost. And lastly, the way we communicate in our office is the emphasis is on safety. And a lot of things go into safety. Precision, guided surgery, protocols, timeout protocols. Maybe 50% in this room had surgeries in our office by Aria and by myself, and maybe by Dr. Herman soon. You know that the surgeries are precise, meticulous, and very, very efficient. That's perceived by the patients. So they want to know, what are you doing for my safety? Because they trust you. So that's a key component. So that's the 50% of your success right there and then, the patient communication. So let's talk about the rest of the 50%, and that's going to be clinical. So we talked about patient communication. Solid planning. What does solid planning mean? Solid planning is when a patient comes to see you, you don't have to reinvent the wheel. We have general dentists in the room, we have specialists in the room. The planning is something that you do every day. You're not reinventing something every time the patient comes in. You have a system. Now, the key for every good plan is what? Is accurate records. Records. We're dentists. We're meticulous. We're OCD. we need those accurate records. We're going to repeat that impression if it doesn't work out. We're going to repeat that x-ray. Because especially, since we're talking about implants, especially with implants, if you have inaccurate records, it's going to trickle down to the procedure. And that's going to mean misplaced implants, angulated implants, too deep, too shallow, too mesial, too distal. So we call it garbage in, garbage out principle. So we need the no garbage in, we need good stuff in. So for implants, very simple. CT scan, standard of care. No dentist or specialist should do an implant, a single implant without a CT scan. Even if they're like the world champion in implants and like have all the accolades, because you never know what's hiding behind the corner and their blind spots. So that's the standard of care. And CT scans need to be diagnostic, obviously, high resolution, and they need to be full arch. So if you have a scanner in your office, we work with a lot of dentists that have scanners. We will use your CT scans, and we've done so many cases where the scan was done in your office. Always take a full scan, obviously, because we make guides off a full scan. The second record is our optical scan. I prefer optical, we all do, because when you take a physical impression, you got to rescan it. You lose the accuracy, you lose some data. So we go straight from digital to a digital platform, and that's the best for planning. So full arch scan, whether it's a single implant or it's a full arch or a quadrant, and we use that optical scan and we can create wax-ups, virtual wax-up in the office. And our team, Jose is the leader of that department in our office, Jose Franco, and he's very well trained to take all the data, CT scan, optical scan, do the merging, do a virtual wax-up, that's something you did, and then we can base our planning off that, and that's ideal. Now, I call it in-house virtual wax-up or Jose wax-up, and by the way, when he does it, it's like 95%. Ready? So REI and now Dr. Herman can go in there and we can start planning our implants. It's a luxury that we have a team that is so well trained. Now, that's also the limitation of a virtual wax-up in-house, because we're not technicians. Jose is a high-level assistant that knows the technology behind all the planning. So we need to do some tweaks and we need to change angulation, but for one or two teeth, an in-house virtual wax-up is great. Once you start to have greater segments of missing teeth, let's not put the pressure on Jose or me. We don't need it. We send this to a lab. We have a technician that does a diagnostic wax-up with 3Shape or other software, and we can plan off that. It's the same principle, okay? And we learn a lot about where we want to place those implants, so the restoration is easy for you, because we don't want to have misplaced implants, non-restorable implants, one of those aesthetic nightmares, okay? We don't want that. I want to have great dreams at night, okay? I want to pass out. Okay, now from the wax-up, you can also see the problems or the limitations. We see that there's a big ridge deficiency. It's great to identify it, not just because we might need pink porcelain or we might need some other prosthetic considerations, but also when we plan implants, we need to engineer the case. So for example, when we have a significant crown to implant ratio that is unfavorable, we might have a discussion ahead of time that you need to splint those implants, and we might want to build this into the patient's conversation, because the implants are not going to fail necessarily, but you're going to get more prosthetic complications. When you have the less favorable the crown to implant ratio, you're going to get more prosthetic complications. We talked about it in one of the previous meetings last year. More screw loosening, more screw breakage, and more nightmares and more wasted time, okay? So splinting is very important in these types of situations. So the records are important. The records are really the basis of what we do. And if they're not accurate, I just don't accept it. If my assistant takes an off-angle x-ray with a concut, and these things happen, take it again. Don't be scared of the patient. The patients, there's a way to talk to them about taking another angle and getting it better. Don't compromise on that, and I know we don't. So what do we do with the records? The records are meant for us to plan implants, to plan a single implant. For molars, obviously, screw access, if possible. And for a single molar, a virtual wax-up is quite enough. Now, one thing that you might not be thinking that we're looking at, so when we plan the implant, we don't just make it look kind of nice. We want to think about prosthetics, so that's the depth of placement, that's the angulation buccolingual, but also we try to aim the trajectory of the implant to be parallel to the contact areas. If it's not parallel to the contacts, you're not going to have ideal contacts with your restoration and ideal embrasure spaces. And it's very simple for Jose to start doing it, and for me, maybe to myself and Ari to tweak it, and to get those contacts so we have a better chance with the restoration. Because what's the number one complaint about molar implants? Food impaction, right? Right, and that's because of that, right? And we have enough stories to share, and nobody's perfect. So good contacts. That works really well. In the aesthetic zone, yes, we're going to aim for the screw access through the cingulum, if possible. If possible, if the occlusion permits, if we have the bone in the right spot. But sometimes it's not possible. And we want to detect this ahead of time. So there's going to be an angled abutment, the custom abutment. There's going to be an angled screw channel, which our system allows. You can actually have an off angle, and you can correct it with an angled screw channel. And that's something that really saves us in many of those aesthetic cases. And same thing with the contact areas, even in the aesthetic zone, even more so. So the implant, when I was training in the 90s, beginning of the 2000s, I put in the middle. But what middle? The middle is not always the middle. There are nerves, there's prosthetics, so it never made sense to me, that middle concept. So this is precise and this is accurate, and we have that option to do it this way. As we evolve with our techniques and with our knowledge, our implants are getting deeper. If in the past we planned our aesthetic implants at 3.5 millimeters, and you can get it that accurate in the aesthetic zone and other places, we plan it deeper now, 4 to 5 millimeters. And if you get if you get a bit uncomfortable with a deeper implant, there's ways around it. These implants will have better bone, and we follow something called the zero bone loss concept. And we don't have time to get into that. But the concept of zero bone loss, and of course not a guarantee, is the implants need to go in deeper. There has to be a certain connection, and also an immediate custom abutment if possible. You get better bone preservation, better biologic width around the implants, okay? So that's something that we all slowly need to adapt, and we slowly, as cases come in, we educate our dentists about the deeper placement, the zero bone loss, as best as possible. So let's move on to 2 implants or 3 implants. Now, when I say over-engineering, that's not over-engineering. That's under-serving, okay? This is a nightmare. 1 molar, 1 implant. 1 molar, 1 implant. Now, if this molar, for some reason, was a 14 millimeter molar, well, you can get 2 premolars in there, okay? But that's a regular molar, okay? And it's a nightmare for you, not just surgically. By the way, it takes a lot of skills to do this, to get it in there. Very stressful. I don't like stress. I have enough. So you can get them screw retained, but at what cost? And by the way, this boosts our business, because a lot of these implants end up being removed, and they need to be taken out after a few years. This is an upper molar, over-engineered, under-cared, underserved, in my opinion, because they go in the trash eventually, where they belong, because there was not a right treatment. Maybe it was right 20 years ago, but we shouldn't have more than 1 per tooth, and if we have the space And the plan is great. We said solid plan. That's a solid plan. With the right choice of implants, it's going to work out. Now, there's also the patient's healing. Not every patient heals. We are at about 93%. It's pretty good. But the 7%, they don't heal. Okay? So we're not at 100%. But in the aesthetic zone, we got some dilemmas. And I wanted to simplify how things are looking from our perspective. A lot of patients want to tell us, I'm going to lose a lot of perio disease teeth. I want implants. I want to be able to floss. But we might not be able to place individuals. It's actually rare. This patient had a big jaw, and a lot of bone was created with PRF, with bone grafting, able to space the implants properly. We're able to guide them in. Soft tissue management, and that's something that every periodontist should be able to manipulate tissue in the optimal way. Meaning, within what was given to him or her, they should be able to make the best out of it. Like you got Play-Doh, you can make something out of it, and that should look pretty. Now, if you got nothing, then you can't always do that. But if you have something to work with, you can get some tissue, and you can make them individual, but that's more the exception to the rule, in my opinion. It's pretty rare that patients have that opportunity to get that type of result. It's of course easier when you have a full arch. Awesome, let's go, 16 implants? How many can we put in there? You don't need that many. This is good to over-engineer and factor in failures. So implants are placed, fully guided and very predictable, but the dentist, the prosthodontist, decide, I don't need that many. I know we plan for some of them to fail, but I'm not going to use all of them. And that's okay. It's not a big deal. It's not a big deal. Take off the healing abutments, let the tissue close. I'm good with 6 based on the mechanics of this case. And you might do this case differently or the same or completely different, but the point being made here, it starts with a solid plan that had a concept where we wanted to over-engineer. Not to squeeze 2 implants in a molar. That's not over-engineering. That's not good. But to have a full arch, factoring in some implants might fail. They didn't. Great. We put them to sleep. Very easy to do and restore. In Beverly Hills, patients lose 1 tooth at a time. They lose a bridge. The most common situation is losing a bridge. Abutment fails, you just bought yourself 2 implants, 3 implants. So that's a more common scenario in the aesthetic zone. So when you get those nubs, a lot of dentists get stressed out. Okay, what do we do? 3 implants, 2, you've got a system. You don't have to reinvent the wheel, and we are always happy to help you with the treatment planning. Not that it's that complicated and that you need help, but it's always good to plan together. So when a patient like that comes in, there's something called a pontic. More than 3 missing teeth or 2 teeth, we got to consider that pontic for spacing reasons, for aesthetic reasons. We might need some pink porcelain. For the single implants, you can't always get the aesthetics. Okay? So here are the options. Okay? It's very simple. Missing all 4 incisors mechanically makes the most sense. 2 implants in lateral position, pontics, straightforward, most common. If possible. Sometimes the bone sucks. The bone is bad. So sometimes we place the implants in the central position and cantilever. Whether it's all splintered or not, different story. Whether we use pink porcelain or not, or emergence profile, or hopefully we sink them deep enough. And sometimes a variation on the theme. Okay? Gina, I got this slide for you. All in one. All in one. Okay, that's the menu. Okay? It's not that complicated. And I show this to patients. Sometimes we do have multiple implants, and these are zirconia implants. Nothing wrong with the zirconia. And Tom knows this case very well. He's like, Ziv, can you do something for me? I'm like, Tom, do you have some simple cases? Never. So never, right? Never, because you do the simple cases, right? And what you don't want to treat. Yeah, that's why specialists were, God invented specialists. Dump everything on us. That's fine, as long as they pay the bill. We're good. But there was nothing wrong with the zirconia. It was mostly the planning. The plan was not solid. The plan was fluid. Soft tissue for implants is as important as bone, if not more. If not more. I want to say that. Because if you have great bone, awesome. If you don't have good soft tissue, that implant is going to end up in the garbage, okay? And very commonly, if you're going to look at your cases, the failures, go back to the first photograph, look at the soft tissue, look at the amount of keratinized gingival tissue, that stippling that we all see on the adjacent, but we don't see on the implant. It's all mucosa. It looks kind of ugly, but the ugliness is not, that's not going to kill us. It's the bacteria going in there and then infecting it, and then that implant is just a removal. By the way, we have another source of income in our practice, implant removal. Implant removal, the cost for the patient is equal to implant placement, because it's very difficult to remove. They're integrated. We have a whole, growth center. And not that we don't remove our own implants, those 7%, but we also get referrals, because there's a way to remove implants. And these implants are going to be lost because of a soft tissue defect. And if it doesn't look like a big deal, well, look at the soft tissue on the adjacent. You have a lot of keratinized tissue. You have gingiva. The tissue is robust. It's pink. It's beautiful. But on the implant, it's flimsy. And there's pull and mucosa. These things fail. Look at the soft tissue when you are referring the patients. Every week with our patients, your patients, referrals from the outside, patients self-referred from our website, self-referred from YouTube, seeing our videos and just hearing about that we do this type of stuff. And then, hey, look, you need that treatment. You need that implant treated and bone grafted. This is from this morning. The dentist is not here right now, but this is from this morning. And it's nobody's real fault. There was some calcium sulfate, but these implants eventually need to be removed. We do the best we can, but in the meanwhile, we treat them. Implant complication treatment. And it's going to be more and more because more and more implants are being placed. So where indicated, where possible, if you look at the soft tissue and you don't love it, and you see that concavity, and you can see that mucosa growing in there. I mean, you don't need to be a periodontist. You can see it. I mean, we're dentists. We look at details. We're very detail-oriented. You can do a graft. And for a periodontist, this is not a big deal. And you get that tissue back, as best as possible. Obviously, this is a successful case. You get good tissue. Great to do it preemptively. That's part of the solid plan. This is very common in the posterior mandible. Any periodontist, any surgeon should be able to do soft tissue grafting, and you can get that keratinized tissue, which is really nice, and you're getting that runway for implants, and you can place the implants, and you can get great tissue and great bone and a better result. I'm not even talking about aesthetics. I'm talking about longevity. Every week, I'm treating a sick implant, and it's sickening, but that's somebody's got to do it. Okay, so how to diagnose this problem? Very simple, very simple. Bleeding on probing is one thing. Pain, discomfort, the floss kind of hurts, it gets stuck, it throbs. It doesn't mean we need to take the implant out or do the graft right away. There's other ways where we treat peri-implantitis, and we need to do this, but just pull on the cheek. Pull on the patient's cheek gently, and pull on the lip next to the implant, and see how the tissue moves, okay? And Dr. Farai here, we saw 2 of your patients just in the past, month, with this type of problem, and we're treating it. And how is it treated when the implant is already in there and the crown is in there? Well, we got to kind of, it's like Legos. You got to disassemble and start from the ground up, and it's not a big deal. Not surprisingly, there's not enough tissue. Not surprisingly, okay? And it's an implant that was placed, it failed, it was placed again. It's not a problem. Things are not supposed to be 100%, and we treat it. So what do we do here? Disassemble the thing, right? That Lego construction, easy. Expose that implant. And what graft? No, we're not going to graft. We're going to connect a cover screw. Okay, so that's just the lid on the implant. And let the body do the rest. The body is going to just close up and collapse. That's what we want. Let it heal for like 6 weeks. It's spontaneous healing. The body doesn't like holes. It's going to close up fully. And after 6 weeks, come back, do a graft. Okay, I know it looks very detailed. There's a lot of details in here, but the bottom line is, when it heals, you get that tissue back that we lost. And the patient needed that. And here you have that robust ridge. And of course, this is a successful case because I want to show you the potential. And that implant is still sleeping in there. We wake it up, connect the healing abutment, and you got the tissue back. And it's great. And then you either use the old crown or the new, or make a new crown. But the potential is there. We just have to recognize it, okay? Because the soft tissue is what's going to kill a lot of our implants. So when Tom called me like, Ziv, can you do something about this case? Don't hate me, don't kill me. No, look, this is a soft tissue problem. And it's a bit tricky because we don't want to lose more. So it needs to be done in a very refined way, very gentle. There is tissue, you just look at it, it just falls apart. It's friable tissue, okay? And no pinhole or grafting is going to help to cover. It's a pulling problem. So I told Tom, you know, I might not be able to do it. I got it checked. So we took an optical impression. Jose printed the models. I cut up a Post-it, literally. And I'm like, okay, this is the size of the graft that I need. Let me go back to the palate. Let me see if I can harvest safely from the palate. Okay, I don't want to compromise anybody's sensation or make him hate me, okay? I mean, if they hate me for like a week when it hurts, but after that, let's be friends. So I did that simple simulation on the model, and I was able to take it from the palate in a relatively simple way, really, and stabilize it and let it heal. And you got that band of attached and keratinized tissue, and then we complete the rest. So it's possible to do, and the body's going to heal and is going to work with us when we give it the right circumstances. Going back to the common cases where bridges fail and you got these teeth and you know that crown lengthening is probably not a good option. We need something definitive. You can see the interocclusal space is pretty tight and we need implants here. Doesn't mean we need to plant 3 implants. It's not necessary. Plus that pontic site has no bone. I'm not going to squeeze an implant and involve the patient with grafting. A 3-unit bridge it is. Now there's a way to do it also in a way that is elegant and predictable and helps the restorative process later on. We plan on immediates, we print the guide in the office, we send that guide to a lab. You don't have to do this in-house. Based on that guide, we know where those implants are going in, where they're going to fit, right? And then the lab can make custom healing abutments. It's a great thing. The lab can make those custom healing abutments to preserve how the teeth were before. Okay, and then the key, like I said before, you got to take those teeth out like diamonds, not rush, not break the bone. Once the teeth are out, we can guide the implants in. Now, the question is, we got the implants in, okay? So that's very easy. It's very predictable. We had a solid plan. We're now in the process of replicating it. Now, in order for the components to fit, we need to figure out the timing of the implant. Timing is the position of the platform around its axis. And for this implant, we have 6 positions. Now, if I'm a little bit off, that thing is not going to fit, and it's true for a temporary crown. That problem has been solved. It's easy. You take the guide ahead of time, and you mark timing. So I know that the flat part, and these are called fixture mounts. These are the components that connect to the implant and deliver the implant into the jaw. This is a red Sharpie. It's nothing fancy. And I know that the flat part needs to be in between. Now, what happens, you place the implant, it's not stable enough. The torque value is not enough. We got to drive it in. Now we lost the timing. No, we didn't. We didn't, because we can use those fixture mount in the right orientation. You can find the timing even if you need to drive them deeper. So we check the implant stability quotient, the ISQ. It gives us a first numerical reading, and these implants were good. Why do we need to graft? Well, there's always a gap. Implants are placed more palatal. We need to graft on the buccal. We call it gap grafting. It follows the 0 bone loss concept. It's the immediate placement in a depth that is at least 4 to 5 millimeters with custom healing abutments that are flat, so the patient can still have their flipper, their temporary bridge, their Maryland, their bonnet restoration. It doesn't matter. And it's possible to do. And everybody should be able to do this. And we offer that. We don't We don't like to confuse matters. We don't charge the patient off for an abutment or for a temporary. That's all factored into the fee. It goes back to the patient. When the patient goes through this type of treatment, and then the patient has a great experience, we know what that feedback does to your practice. And I hope you enjoyed this short presentation. Thank you.